Please welcome American Academy of Pediatrics, California, Chapter 2 Medical Student Representative, member of the Resident Research Awards Committee, and MD candidate, class of 2022 at UCLA, Emma Burdekin.
Thank you so much, Dr. Teresa. I am thrilled to be presenting this year's awards section. The AAP California chapter called for abstracts on scholarly projects by pediatric residents and medicine pediatric residents from CHLA, Harbor East LA, Kaiser LA, Loma Linda, UCLA, and USC. Students from medical schools in the Southern California counties of Kern, Los Angeles, Riverside, San Bernardino, San Luis Obispo, Santa Barbara, and Ventura were also invited to submit their abstracts. 3 abstracts were selected to receive an award. 1 abstract was selected for oral presentation. The 3 poster presentation awardees, each receiving a $200 award, are Dr. Connor Mitrovich from CHLA, Dr. Brenda Rigger from CHLA, and Paige Kingston from USC School of Medicine. Congratulations to the 3 of you. Selected for oral presentation, recipient of a $400 award, and our next speaker is Sonul Gupta from UCR School of Medicine. Sonul Gupta is a 3rd-year MD candidate at the University of California, Riverside School of Medicine, currently investigating what breastfeeding mothers desire as incentives for breast milk donation in the Inland Empire. She is also leading a group of students to create the first breast milk depot and milk bank of the region. Sonul is also an active board member of the Student-Run Healthcare Leadership Designated Emphasis at UCR, and is currently the lead for a PDSA QI project within the Women's Health section of Unicare Community Health. Prior to medical school, she obtained her Bachelor of Science in Molecular, Cell, and Developmental Biology from UCLA. Upon graduation, Sonul plans to pursue a career in obstetrics and gynecology and will continue applying her passion for improving maternal, fetal, and reproductive health locally and globally. Sonul will be presenting Understanding the Motives of Donors for a Student-Run Breast Milk Bank. Congratulations, Sonul, and thank you for speaking to us today.
Thank you so much. So like Emma mentioned, my name is Sonul Gupta and I'm a 3rd-year medical student from UC Riverside School of Medicine. I know we've been talking a lot about COVID and opening schools, but we're kind of going to change gears here and I'm going to talk to you a little bit about breast milk banking. So let me just go ahead and share my screen. Alrighty, can everyone see that? Great.
Yes, it's perfect.
Perfect. Okay. So like Emma mentioned, I'm going to be talking to you guys about understanding the motives of donors for a student-run breast milk bank. So before we get started, I just wanted to take a moment and introduce my team because this is very much not a one-woman show. So from left to right, we have Dr. Brenda Ross. She's the director of our Milk Depot, and she is also a doctorate of maternal fetal medicine at the UCR Women's Health Center. We have Dr. Samar Nahas. She's a gynecologist oncologist. She's one of our research mentors, and she is the director of the UCR Women's Health Center. Next, we have Dr. Lisa Stellwagen. She is a pediatrician based out of UCSD, very well versed in NICU care, and she is the current and first UC Health Milk Bank Director. We have myself, and then an outstanding group of medical students. Jordan Smith, a current MS4 at UC Riverside School of Medicine. He's actually applying to pediatrics this year. And then we have Natalie, Robert, Priya, and Samia, also great MS2s on the project. So before we dive in, I just wanted to provide you all with a little bit of background because after all, why would students in Southern California be wanting to create a milk bank? So for starters, I'm sure it's because you may all know, there is this very life-threatening and devastating illness known as necrotizing enterocolitis, or NEC for short. And this particularly affects the intestines of premature infants. Pathophysiology-wise, the wall of the intestine in these infants is invaded by bacteria, which causes a local infection, and then the inflammation can actually destroy the wall of the bowel. So you can imagine once the wall of the bowel is destroyed, perforation occurs, all of the gut bacteria spilled through, systemic infection, septic shock, and even death. So the incidence in the United States is estimated to be about 1 to 3 per 1,000 live births and accounts for about 1 to 5% of NICU admissions. It typically develops within the first 2 weeks of life, and one of the first signs that an infant might be heading that direction is they'll start having this inability to tolerate their feedings. This typically occurs in about 10% of premature infants, but rarely affects full-term infants. And more than 90% of cases occur in very low birth weight infants. So this is defined as a birth weight less than 1,500 grams, which is about 3 pounds and 4 ounces. So what happens when a baby gets NEC? Well, a lot of things, right? And a lot of things we don't really want to see. So for example, when a baby is admitted to the NICU, they're not feeding for about 2 weeks. They have a lot of antibiotics, potentially a ventilator. They can be put on IV nutrition, get bowel resections. We learned about short bowel syndrome earlier in the day, and we saw a pretty gruesome picture of that. And not to mention very high mortality and being a huge cost to the baby, their families, the hospital, and then insurers. So on the right here, for future providers and for providers, I'm sure this is a classic image of what necrotizing enterocolitis looks like on an abdominal x-ray. You can very clearly see the distended loops of bowel. And then to the right of that, we have what one of the bellies in one of these kiddos would look like on physical exam. And you can see again, it's just very distended and not a pretty picture. So while the cause is unknown, one of the best ways to tackle this illness is to focus on the prevention and targeting risk factors. And of course, one of the biggest risk factors that we've already harped on is prematurity. And one way to go about this would be to prevent that. But as a field, we still have a ways to go before we actually figure that part out of the puzzle piece. Other than that, other studies have shown good evidence that the following interventions have been proven effective. So these include things like prenatal steroids to reduce neonatal respiratory distress syndrome, and then the use of human breast milk. And so because of this data, many institutions across the state and across the country are starting to use donor breast milk as a bridge if mother can't produce milk herself for her infant. And again, breast milk has a bunch of benefits, not to mention lowering the gastric pH, increasing motility of the intestines, and then promoting the secretion of IgA, which altogether lowers the risk of this microbial imbalance and overgrowth, which have been implicated in the cause of necrotizing enterocolitis. So I just wanted to share one of the studies that I thought was interesting with you guys. So this study is known as the Domino trial. It took place in Canada, done in 2016. And this is a study that primarily looked at donor breast milk versus formula on the neurodevelopment in infants of very low birth weight. It was a double-blind, randomized trial, and these infants were recruited from 4 NICUs across Ontario, Canada. They were recruited within 96 hours of birth between October 2010 and December 2012, and follow-up for that neurodevelopment component of this project was completed in July 2015. So these infants were either fed donor milk or formula for 90 days or to discharge when mother's milk was unavailable. Although this study mainly investigated neurodevelopment, as part of it, they looked at the percentage of infants who developed necrotizing enterocolitis on donor breast milk versus formula. And as you can see in this blue box here, there was a statistically significant lower rate of all stages of NEC in infants fed donor breast milk versus those who were fed preterm formula. And I believe the sample size was about 180 in each. And again, the p-value was 0.01. If you look right below that, it says stage greater than or equal to 2. So there are multiple stages of necrotizing enterocolitis, and stage 2 just refers to proven NEC, meaning that it's meeting the criteria based on a subset of symptoms. And again, that was also significant for a 5% risk difference between donor breast milk and preterm formula. Moving forward, the California Perinatal Quality Care Collaborative, or the CPQCC, actually from 2007 to 2013, implemented donor breast milk at 22 hospitals across the state of California. They found that overall, as they used it, or overall after they started using private donor human milk, which is the PDHM you see on the slide, when they started increasing it from about 38 to 81%, breast milk at discharge increased to about 53%, and necrotizing enterocolitis rates dropped to 2.9%. So this is a pretty big deal. And then they noticed that as a hospital started implementing this overall, breast milk feeding rates at discharge by mom increased by 10%, and necrotizing enterocolitis decreased overall by 2.6%. However, one of the proposed cons to donor breast milk is that it's thought to be pretty variable in price and typically unaffordable to the middle income family. But as demonstrated by the study published in Pediatrics in 2018, it suspected donor breast milk's suspected reduction in NEC rates support its use over preterm formula, and that's the PTF acronym that you see in this slide, regardless of the cost saving. So this is really important to consider for hospitals when they're comparing the cost versus benefit of whether or not to provide this service. And lastly, if that's not enough to convince you that breast is best when available, the American Academy of Pediatrics actually published a policy statement in 2017 titled Donor Human Milk for the High-Risk Infant, Preparation, Safety, and Usage Options in the United States. And I believe the two committees that created this policy statement was the Committee on Nutrition, section on breastfeeding, and then the Committee on the Fetus and Newborn. So I just wanted to show you guys some of the main key points that they had at the end of this article. And there are 5 points altogether. I just highlighted some of the things that I thought were interesting. So first off, donor human milk may be used for high-risk infants, and there should be priority given to those who are of very low birth weight. This milk, however, that's being given to these infants should be screened thoroughly by the Human Milk Banking Association of North America, or HMBANA for short, milk banks. And then once that milk is thoroughly processed and approved according to their standards, it's acceptable for these infants. And then at last, if you scroll down and look at point number 5, financial insufficiency should not be a reason for why high-risk infants don't have access, as the AAP really identifies donor breast milk as a medical necessity. So even with all of that research to support that exclusive breastfeeding is the best option for newborns, Southern California still remains an underserved area for affordable donor breast milk. While it's unknown the exact percentage of babies who consume human breast milk in the hospital, it's thought to be estimated between 89 to 92%. So this is obviously not at 100%. Interviews with NICU clinicians in the Inland Empire, or IE for short, done by members of our own team, really discovered that donor breast milk in our area at least is $8.50 an ounce, and that's pretty expensive. And that kind of indicates that hospitals, at least for the ones that we interviewed, are really purchasing their milk from private companies, kind of like Prolacta, if that rings a bell for anyone. Why breast milk tends to be so expensive in the first place is, first of all, it's a human tissue, and then there's a lot of cost that stems from screening it, processing it, shipping it, because it really requires a lot of cold storage so that it doesn't decompensate when it's being shipped from the nearest milk bank to hospitals or families alike. However, but if it was purchased through a Human Milk Banking Association of North America, or HMBANA Milk Bank, the price decreases about 50% to $4 to $5 an ounce. So the thought is, how many milk banks or HMBANA milk banks are there in the state of California? So there are actually only 2. The first that was opened in 1974, and it's Mother's Milk Bank in San Jose, and that's the star kind of in Northern California. It's in Santa Clara County. And the second milk bank actually just opened last year in 2020, and this is the University of California Health Milk Bank. So again, there are only 2. So with that being said, Northern California and kind of a portion of Southern California is kind of taken care of by that. But we still have this vast region in the middle and the eastern sides of California that can't really tap into these resources, especially given the pandemic. So for starters, the Inland Empire is composed of San Bernardino and Riverside counties, and it's one of the fastest growing population centers in the United States. The IE, which is made up of San Bernardino and Riverside counties, is located about 40 miles east of LA. Oddly enough, San Bernardino County is actually the largest county in the United States, and the population of the IE has a population of 4.5 million people, with 2.3 million of those people being women. So this is taken from the California Department of Health, and as you can see by this graph, compared to the state of California, which is in blue, the IE counties consistently have had more live births per 1,000 women of reproductive age from 1995 to modern times in 2017. So again, California is in blue, and then the IE counties are in that yellow color and in green. So now if you overlay Santa Clara County, which is where the San Jose Mother's Milk Bank is, and San Diego County, which is where the UC Health Milk Bank is, the numbers of live births in these counties are more consistent with California's as a state, but the IE counties significantly have higher rates. And if we really zoom into that last year that's recorded in 2017, we can very clearly see that San Bernardino and Riverside County have higher birth rates, with an almost 6-point difference between Santa Clara County and San Bernardino County. We also know that traditionally Riverside and San Bernardino counties have had lower individual and household incomes as compared to Santa Clara and San Diego, and yet these are still the communities that have more children but do not have the benefit of having a valuable resource like a milk bank in their region. This graph was also adopted from the California Department of Health, and if you look at the County of Riverside's breastfeeding rates, although this graph shows a natural increase and a steady rise of rates from 2012 onwards, compared to California counties, Riverside's value is at 92.4%, which is evidently in the worst quartile of California counties. So again, this is breastfeeding rates, and to put it all together, not only are there more live births in these lower income households in the region, but fewer of these women are breastfeeding. So with all of that being said, one way to mitigate these differences is to create a milk bank. Milk banks are known to provide support systems for breastfeeding mothers, their families, their infants. They can drastically increase breastfeeding rates by virtue of providing lactation consultants. And then by supporting all of those things, you can drastically increase access to donor breast milk at lower costs. Yet there are only still 2 in the state of California. And as there are only 2 milk banks to theoretically provide these resources, and in a time of a global pandemic, it's unrealistic for women to drive miles away to obtain these resources and or donate their milk. So as a way to combat this geographical burden, we can put our efforts to creating things like a milk depot. So a little bit of terminology for you guys. What a milk depot is it acts as a collection site for breastfeeding mothers to drop off their milk. And this depot is then responsible for getting that milk to the milk bank monthly. A milk bank kind of acts as the main hub for all things related to that breast milk once it's in its facility. So I kind of wanted to show you the responsibilities of what each entity would have. So for a milk depot, you need to maintain a California Department of Health tissue bank license. You need to have an MOU with the milk bank, a freezer in a secure location with an uninterrupted power source, obviously away from patient care with a lock on it. It must be kept at least -18 degrees Celsius or lower. There needs to be adherence to an SOP regarding the milk storage, and then obviously collecting the milk from the donor herself and holding it until shipping or pickup date. Now, if you decide to become a milk bank, not only do you have to have those responsibilities and having a tissue bank license, but you're also responsible for screening the donor and approving her to donate. So this includes serologic testing for infections like HIV, syphilis, hepatitis B and C, and the milk processing and distribution. And there's also a very extensive screening process for the milk itself to make sure there are no pathogens in it. You're also going to have to assume all liabilities for the donors, the milk product, and then you're actually going to be responsible for the shipping and courier costs for your depots. So whenever they're shipping their product to you, you would be responsible for that cold storage shipping. And then of course, lots of insurance for liability. So for our own personal project at UC Riverside, we have identified the UCR Women's Health Center as a place that we want to house our milk depot. We chose this location as it has ample faculty, staff, and freezer space for this operation, and we are currently working towards obtaining our tissue bank license and purchasing equipment like our freezer. And then for our milk bank, we chose the UC Health Milk Bank. This entity will be responsible for screening and improving our local Inland Empire mothers. So I just wanted to walk you guys through the process of how this would all go down. So if a mother in our area was interested in donating, she would go online to the UC Health Milk Bank's website or app, register as a donor, where she would then be set up with a set of labs and forms to fulfill in her area. Upon screening approval, she could then drop off her milk at our facility, and then she could do that weekly, monthly, however she sees fit, since breast milk has a shelf life for typically 1 year in a freezer. And then there would be a designated time that she could drop off her milk here. The milk will then be stored in our freezer at -20. The medical assistants would record that donation, and then they would set up a shipment or a pickup date with the UC Health Milk Bank monthly. So again, this could be a shipment, or the courier could come and receive the milk themselves. The milk would then, once it's at the UC Health Milk Bank, be pasteurized, screened for pathogens, and then aliquoted in the appropriate amounts to then be sold to California hospitals and families in need. And I know this picture says the San Diego Blood Bank, but that's just the entity and the facility that the UC Health Milk Bank is currently operating out of. And that's actually one of the employees down below. So just to reiterate, UC Riverside is going to be the milk depot. We're operating out of the UCR Women's Health Center, and we have partnered with the UC Health Milk Bank, which is operating out of San Diego Blood Bank. And this partnership has been ongoing since May of last year, and we're really excited about that. So as students invested in the creation of this project, we really wanted to do our due diligence and create a milk depot and eventually a milk bank that would really serve the needs of the women who are in this area, especially if they're choosing to enroll as a breast milk donor, because that's a huge deal. We also really believe that an important component of fostering breast milk donation is understanding the donor herself. Previous studies, specifically one in 2019, it was a systematic review, suggested that mothers' motivations derive predominantly from altruism, whereas the biggest barrier to donation stems from cultural and religious beliefs. So the primary aim of our study was we really wanted to understand donors' motivations and see if their motivating factors were different from previous studies. We also believe that as a result of this understanding, we can really build an ethical donor incentive program that will ideally build a tangible support system for mothers, young infants, and their families, increase rates of successful breastfeeding in the Inland Empire, promote a culture of breast milk donation, and thereby increase quantity of donations and access of donor breast milk for NICU infants. And ultimately, by doing all this, we really hope to provide culturally responsible care. So here's our timeline. MS2s, 3s, and 4s are currently all working on this project, and we initially spent over 6 months in trying to obtain IRB approval. After that, then we had to do a little bit more waiting, and we went through a series of steps to get our online research instrument or our online survey approved by the sites and forums we would be posting it on. So since then, since I believe July 2020, we've been distributing our survey, and we have about 80 responses so far. And we have about 5 more months to go before we hit our goal of 250. And then eventually, by compiling these results, we are going to build an ethical donor incentive program specific to the Inland Empire. So our current study is cross-sectional with data collected over 12 months. Participants are mothers who are breastfeeding or who have breastfed in the past. They've been recruited through personal networks, referrals, social media, and local clinics, specifically OBGYN and pediatrics clinics. Our online survey is operating out of Qualtrics, and the responses are remaining anonymous. The responses are mainly being tabulated on Excel by zip code, age, births, breastfeeding experience, and milk production. And the reason why we chose zip code as our first demographic feature is because we really want to go and back check to make sure the zip codes are actually coming out of Riverside and San Bernardino County, as we want these responses to reflect the IE. And then, of course, we're also monitoring the motivations for donation, and that's being assessed both by free response and multiple choice. So I just wanted to show you kind of the IRB infographic that we've been distributing on these various online networks and forums. So as you can see on the left-hand side, a mother can pull out her smartphone, go to the camera app, and scan that QR code, or she can type the link of the survey into her internet browser, either on a computer or on a phone, and each will access our online survey. And then if she's actually interested in donating, we have an email where she can contact us at. And then I know it says currently that please consider participating if you are fluent in English, but we're excited to say that we're currently translating our materials and our survey into Spanish. So if a mom was to click a link on that flyer, it would take her to this page. And on the left-hand side, you can kind of see the introduction to our survey. And if you were to keep scrolling, you would see the informed consent. If she clicks yes to participate in our survey, she would then be led to this first page, which records her demographic information, which is again, age, how old she is, zip code, and how many children she has, etc. As she proceeds through the survey, next she would be directed to kind of what she feels is absolutely necessary when considering compensation for breast milk donors. And this, again, is being qualified as her motivating factors for donation. So again, you can see money, food, consultants, childcare, access to physicians and healthcare, baby clothing, and mental health resources. And then after this, mothers actually have the option following the screen to use their free responses to describe personally what they feel is best if it's not already on this list. So far, preliminary results from 75 women showed that the most commonly selected factors for donation included gaining access to lactation consultants, mental health resources, and a community of breastfeeding mothers. Only a quarter of responders really disclosed that receiving information about infants positively impacted by their donations is important. So we kind of qualified this as altruism. Approximately 20% of participants indicated that monetary compensation was their primary motive. And when we initially read this, we believe it's because these mothers might have had experience in the past with private breastfeeding companies where there are companies out there that mothers can actually sell their milk for money. And then lastly, 60% of individuals stated that they knew of other women who they thought would be interested in donating. Now we have this graph, which is titled Donors' Interest in Donation and Opinions on Necessity of a Milk Bank. So looking at these same 75 women, you can see on the left-hand side in blue, 44 were very interested or absolutely interested in donating their breast milk. In orange, you can see there are about 31 who are not. And when we looked at their responses, some of the barriers to donation that they noted was that they just have an immense lack of time. You know, these are working mothers or mothers of multiple children, or they just don't have the time because they're taking care of other family members, or sometimes they're actually underproducers of breast milk. However, when we asked these same women if a milk bank in their area would be necessary, there was an overwhelming majority where 64 individuals said it was very necessary or absolutely necessary to create one, and only 11 reported that it was not. And again, this could be due to previous studies with their similar findings of just a difference in cultural and religious beliefs. So like previously mentioned, breast milk donation and the motivations behind that was originally thought to be due to altruism, whereas the biggest barriers was thought to be due to cultural and religious beliefs. Given that the women in our region so far have selected mental health resources, support groups, and lactation consultants as their main motivating factors, this really suggests that breastfeeding women, at least in our area, are poorly understood. Additionally, we also realized that potential donors have a huge access to other breastfeeding mothers, which could significantly increase donor breast milk availability in Southern California. And then last but not least, donors are very supportive of creating a milk bank in the Inland Empire. So why is this information important? We hope to use this information for when we create our own milk depot, which should be happening in the next couple of months, and then transition into a milk bank, which is a few years down the line. Priority of services will really be given to offering lactation consultants, a community of breastfeeding mothers, whether that's talk therapy or support groups, and then mental health resources, as these resources really seem to be most needed by mothers in this area. And then given the overwhelming support of the idea, this demonstrates that there's a great buy-in by these potential donors. And we really believe by that having their support, accomplishing some of these aforementioned goals will really be much more tangible since we'll have their backing. So for future steps, we have about a little less than 6 months left of the study. And again, we expect to hit our target goal of 250 responses. We're happy to report that we were recent recipients of the UC Riverside Center for Healthy Communities mini grant. And so what we're going to use that money for is particularly advertising to get the word out to women who might just be at home breastfeeding right now and might have more to spare in the freezer. And then really use some of that money to start buying some of the industrial equipment that we mentioned. We're also going to be applying for a tissue bank license to the California Department of Health, again, receiving donations, and then eventually transitioning into a milk bank. But again, this is going to be a few years away. Now, I thought it would be nice if there are others out there kind of like us that would be interested in creating a milk depot in their region or hometown. And I can just quickly walk you guys through some of the main steps that one would need to take to create one. So of course, the first step would be to partner with the milk bank mentor. In our case, it's the UC Health Milk Bank in San Diego. But again, there are milk banks all over the country. I know before the creation of the milk bank in San Diego, they were originally a milk depot partnering with the milk bank actually in Austin, Texas. So again, because of this cold storage shipping, you can kind of partner wherever your heart lies or your passion lies. The next step would be to obtain a tissue bank license from the California Department of Health. And this is a pretty hefty price. It's about $500 initially and then yearly after that. So this is the most current new application checklist by the California Department of Health. So you can see like initially there's a few lab forms that really just require normal application stuff like personnel reports, addresses, things like that. Next, you'll need a copy of your California state license for the hospital that you choose to operate out of or the facility. It depends on where you want your milk depot. The next is owner substantiation proof. So this is like partnership agreements, articles of incorporation, boards and directors, things like that. The next things are things like resume and CVs for your employees, a copy of policies and procedures pertaining to the milk depot. So for example, this would be the SOP for the freezer, a temperature monitoring log, things like that. And then next it says an STD screening policy statement. So that's actually kind of something you don't need as a milk depot because you won't be performing that. So in this case, you would probably submit a document stating that you won't be doing that, and instead your milk bank would be doing that. And then of course, that nice hefty little check paid to the California Department of Health. Other steps include securing a space for your milk depot operations, again, away from patient care, identifying a milk bank director. This is typically a doctor, so an MD or a DO, and then appropriate staff. So these are typically medical students or MAs would be appropriate as well. Next would be obtaining industrial equipment. You probably want to allocate $3,000 to $5,000 for that, receiving milk donations from mothers who are being screened by your milk bank, coordinating shipments, renewal of that tissue bank license, and then securing donations for creation of a milk bank. And again, that's a very expensive step, usually requiring at least a couple $100,000 or at least $1 million. So before we finish today, I just wanted to leave you guys with a few parting thoughts. So a sole breast milk diet is the best option for babies up to 6 months of age, and priority should really be given to those who are born as very low birth weight, as demonstrated by the aforementioned studies and by AAP's own policy statement in 2017. Also, birth rates are high in the Inland Empire compared to some of those other counties we talked about, yet breastfeeding rates and financial well-being are lower in this region compared to their counterparts, so there's a significant need for a milk bank in the Inland Empire. And then as providers and future providers, really be a resource for your breastfeeding mothers. You know, as a rotating third-year medical student, I've seen a lot of women come into the outpatient pediatrics clinic where they say that they have too much milk at home and they don't know what to do with it. So if you do run into these overproducing mothers, really refer them to their local milk depots and or the UC Health Milk Bank, or there are other milk banks that they can donate to, whatever kind of floats their own boat. And then by that same token, if you have underproducing mothers, really refer them to lactation consultants. You know, if your clinic doesn't have one, there are private practice lactation consultants all over Southern California that would be happy to help, especially in the time of a pandemic. And then you really also want to be providing that reassurance to the mother of your patients. And then if outpatient families aren't able to produce their own breast milk, and if they have the means, you can definitely advocate that they purchase their own donor breast milk from one of those approved Humana milk banks. And being the pediatrician, you can obviously kind of guide them on what would be an appropriate amount for their infant. It's also important to know that you need to quote unquote understand the customer. So if you are interested in creating a milk depot at the county level, it's important to understand what resources in your region mothers in that area may require or desire. And then lastly, as demonstrated kind of by that previous slide, milk banking is a cumbersome process, right? There's a lot of paperwork that goes into it, legality, licensing, but I believe it's extremely rewarding and worthwhile when you kind of get to see firsthand the babies who are really being positively impacted by your hard work. So here are my references, and I just wanted to say thank you so much everyone for your time and attention. I really enjoyed being here. Please feel free to email me. Any questions?
Thank you so much, Sonul, for that fantastic presentation. And if anyone has any questions, please go ahead and place them in the Q&A.
Again, if there are medical students on this call and you're interested in making a milk depot, feel free to get my email from the slides on that website. And I'm happy to kind of start the conversation of how to go about that, because there are a bunch of UC medical schools out there, a lot of medical schools in our region, and this could really be a team effort if we choose to do it. Great question, Dr. Ko. So the question is, how many milk banks do you think we need in California? So right now, I know we have only 2, but I honestly don't think there's a cap to that number. It could be 1 for each UC medical school. It could be 1 for each area in terms of county. But I would say like ideally 8 to 10 would be the ultimate goal, just so that, you know, each milk bank could be really plugged into a county system of providing that breast milk to these babies in need. But again, I believe personally there's no cap. So if the power goes off, how long can milk stay in the freezer? So that's a really great question. So if the power goes off, ideally you want to have this freezer being attached to an uninterrupted power source. But if that's not the case, you can also have things like a backup freezer that's connected to a different power source. But if the power does go off, typically you want to only have the milk being in a non-freezer situation for about 2 to 4 hours before it really starts to decompensate and start to lose some of those benefits. So have you thought about approaching the Medi-Cal managed care plans to support the operations of either the depot or the banks like IEHP or the Inland Empire Health Plan, or also the commercial health plans like Blue Shield or Anthem? So that's also a really great question, Dr. Ko. Before the pandemic hit, we were really on the ground running. We were speaking to congressmen, different insurance companies. We were also speaking to WIC, which is Women, Infant, and Children, as well as First Five Riverside, to see where we could start inserting ourselves to have people join this campaign. And unfortunately, although some of those efforts have been paused, it's definitely, I wouldn't even say in the back of our minds, but in the middle of our minds, especially now that things are reopening and there's going to be more traffic in these regions. But that's absolutely something we've already thought about. Thank you so much for having me, everyone. Hope you learned something. Enjoy the rest of the symposium.